Thailand, and good afternoon to Switzerland. Hello to Dr. Dennis Pfeiffer. Dennis, are you there?
Thank you.
Okay. Managed to
Good evening.
connect at last. Thank you for joining us. How is the weather in Switzerland today?
It's quite rainy.
Okay. Thank you
So
for.
we had a heat wave the last week. It was
Oh,
pretty hot. Now we are in the rain again.
okay. We're raining quite heavily today in Bangkok too. We'll get on with our symposium. It's the first bilateral symposium between Switzerland and Thailand on sleep health and mindfulness. And this is a very special event for both of our association. It's a result of a warm and fruitful dialogue between the two newly established organizations, and that we share a common vision of promoting better health and well-being through lifestyle medicine. And today we come together across continents, not only between Europe and Asian only, but other continents as well. We hope that we will increase the awareness of the disease prevention and community health as well as public safety through the care of our sleep hygiene, as well as the use of the mindfulness in this respect too. So we are excited to get the experts who will share their insights and research and practical perspective on how the sleep and mindfulness can transform lives. So as we have prepared our speakers today, there are 6 of us. Let me introduce our Thai side first, and then ask Dennis to introduce the Swiss side. For our first Thai speaker will be Dr. Naricha Jirakan Wasan. She is an associate professor of medicine at the Division of Pulmonary and Critical Care Medicine, Department of Medicine, and also she's Associate Dean for International Affairs at Faculty of Medicine, Chulalongkorn University. She is a current president of Sleep Society of Thailand, and she also holds several international society positions, including Secretary General for Federation of Southeast Asian Sleep Medicine, or FSSM, and appointed for the position of head-elect for Respiratory Neurobiology and Sleep Assembly of Asian Pacific Society of Respirology. Dr. Naricha is a quadruple American board certified in internal medicine, pulmonary medicine, critical care medicine, and sleep medicine. And she published extensively over 70 original articles. Dr. Naricha will talk about sleep longevity, and she'll be focusing on health outcomes related to sleep. So that will be our first Thai speaker. The next Thai speaker will be Dr. Tanita Waprasong, and she's a counseling psychologist, PhD. She's a psychologist specializing in mindfulness-based cognitive therapy, MBCT, certified by Oxford Mindfulness in collaboration with the University of Oxford in UK. And she's a lifestyle medicine certified from the American College of Lifestyle Medicine and focusing on the psychological pillars of health and wellness. And she holds a PhD in counseling psychology and a master's in anti-aging and regenerative science, complemented by a diploma in clinical sexology as well. She'll be talking about the science of mindfulness and for better sleep, and providing practical intervention linking mental health and sleep improvement. The final Thai speaker is myself, Captain Retired Dr. Yungyut Mayalap. I'm president of the Thai Lifestyle Medicine and Wellbeing Association, or TLWA. I'm a lifestyle medicine physician practicing at Payathai Group of Hospitals in Bangkok. And I'm also a former elected member of the Thai Medical Council and former government spokesman for 2 Thai governments in the past. I'll be talking about microsleep and also the road traffic accident, which is a major issue in Thailand's safety concerns, especially during the long festive holidays. So now over to Dr. Dennis Pfeiffer, my counterpart, for your side of speakers, please. Thank you.
Thank you very much for the kind introduction. I will just briefly share my slides here so I can show you a little bit what I'm talking about. So I hope you can see my slides already. So good evening from Switzerland, and a very warm welcome to everyone joining us from Thailand, Europe, and around the world. My name is Dennis Pfeiffer. I'm here as the president of the Lifestyle Medicine Society Switzerland, and it's a great pleasure to speak to you tonight, or this afternoon, as for our time zone. And yeah, so we both had the chance, me and Dr. Yongyut Mayalarp, to meet earlier this year at the Lifestyle Medicine Global Alliance in Phuket, Thailand, and I enjoyed it very much. And I'm truly grateful that this has led now to a joint symposium between LMS Switzerland and the Thai Lifestyle Medicine and Wellbeing Association. I will show you on this slide that what we're talking about is a global movement for lifestyle medicine. And I really think that this collaboration between our organizations wonderfully reflects the spirit of lifestyle medicine. It's global, it's also practical, and it's an evidence-based approach, and it's deeply rooted in connection. So I'm very grateful for this kind of event today. And tonight's topic, sleep, is often underestimated in medicine. And as we will hear, it's fundamental to health and closely linked to all other pillars of lifestyle medicine. So I will just shortly introduce you to speakers from our side. So I'm glad to have with me today Dr. Albrecht Forster. He is a sleep researcher and also the head of the Swiss Sleep House in Bern. He will speak about what good sleep is and how we can measure it. And I'd also like to welcome Professor Dr. Björn Rush. He's a professor of cognitive biopsychology and also a sleep researcher. He will share data and insights into insomnia in Switzerland. And last but not least, from our side, or I will actually, I have the honor to open this talk. Additionally to my work with the LMS Switzerland, I'm a practicing clinician with a strong focus on lifestyle medicine. And I also serve as the medical and project lead for a department for lifestyle medicine in a clinic near Basel. And in this role, I've seen that when sleep is properly addressed, it often becomes a turning point, both in prevention and treatment. And this is why I'm very pleased to begin with an introduction to sleep as a key pillar of lifestyle medicine. So I will give you a short introduction in the field and then give over to the other experts here in this field. So I hope this is sufficient for introductions. Is it okay if I start with my talk now, Dr.
Yes,
Jung?
please. Yes,
Okay,
please,
thank you
Dennis.
very much.
Go ahead. Thank you.
So I'm trying to keep the time in mind because each of us has only 15 minutes. So I'm trying to keep it short. So let me begin with a simple question to all of you. When was the last time you prescribed or used behavioral sleep intervention, not medication, as a part of treatment for chronic illness? And I would dare to claim that if sleep were a pill that had been proven to improve cardiovascular health, mood, immune function, metabolic stability, and cognitive performance, it surely would be a blockbuster drug. So, but despite this, sleep is still often neglected in clinical practice. Compared to nutrition and exercise, it's very undervalued. And that's why we are putting it at the center of today's discussion. I think it's a really important topic. And it is an essential and modifiable factor in prevention and health promotion. So I will give you an introduction into this, and further details and for long-term health outcomes and mortality will be shared by my colleagues shortly. So I will show you this framework which shows the 6 pillars of lifestyle medicine. In the lifestyle medicine field, we work with 6 evidence-based pillars, which is nutrition, physical activity, stress management, social connection, substance use, reduction, and also sleep. And sleep is interconnected with all of them. And it's influencing all of these pillars, but it's also influenced by each one separately. So let me give you a few examples. So physical activity improves deep sleep and helps with sleep initiation. But on the other hand, if you exercise too vigorously and too late in the evening, it can also impair sleep. Same as with nutrition. We have caffeine, sugar, and alcohol, which disrupts the sleep architecture. And stress is a really strong factor for healthy sleep because it raises cortisol and sympathetic activity. So it can have a profound and impact to sleep health and making it harder to fall and staying asleep. Social isolation as well, substance use. I've mentioned alcohol, but there's also nicotine and other sedatives. And if you look to the sleep drug market, actually all of these or most of these drugs work as sedatives and maybe help you falling asleep easier, but they impair sleep architecture as well. So one could say that these interactions are not linear. They are forming a feedback system. Poor sleep, on the other hand, increases cravings for sugar and reduces motivation to be physically active the next day. Or stress worsens sleep, which in turn impairs emotional regulation. So you see, it's a very complex framework of feedback loops and interacting systems, and sleep is surely a very important part of them. So I will say a few words about evidence, but there's plenty of evidence in the next talks, I guess. So if we think about how sleep influences health, one could say that in experimental sleep deprivation studies, we see consistently that participants who don't sleep, they increase caloric intake, they decrease physical activity, glucose regulation gets worse, anxiety, irritability gets worse, and also cognitive function gets impaired. So these things, in my opinion, make one thing clear, which is that sleep is a human need and not a lifestyle option, actually. So we treat it as a lifestyle pillar, but sleep actually is a human need. And in contrast, we also know that that in big meta-analyses, comprehensive lifestyle programs that combine movement, nutrition, sleep, and stress interventions significantly improve health and also sleep quality. The effect size here is biggest within patients who already have insomnia, of course. But what we are still learning is that there is a lot of research still to do in the reverse relationship. So we know that if sleep is not good, that it impairs health, but we still have to know better and research better how targeted sleep interventions, for example, improve certain lifestyle behavioral aspects. So if you think about global burden of disease study, which is one of the most comprehensive studies that does research about which risk factors lead to chronic diseases, you see that they don't have listed sleep as a separate risk factor, and which is because bad sleep leads to bad behavioral outcomes in all of these different aspects that lead to risky behavior. So in summary, we can say that poor sleep undermines health across all pillars, but whether better sleep alone is sufficient to shift behavior in long term is not, that remains still an open and exciting question. But certainly it's one of the main pillars of behavioral aspects we should address. So I'm going over to give you some insight into clinical practice as well. So one could say lifestyle medicine is, there are a lot of chronic conditions, but there's lifestyle medicine could be the one solution to all of these chronic aspects. So by improving one's sleep, one's nutrition, one's physical activity, we don't only improve the metabolic state, we also improve all of the other aspects as well. So it's really a comprehensive approach. And we see that in our clinical practice in the Clinic Arlesheim, it's south of Basel in Switzerland. We have quite a bit experience implementing a comprehensive lifestyle medicine approach where we consult patients over the course of several months even, and we work with them very individually in the different fields of lifestyle medicine. And sleep has shown to be one of the most influential lifestyle factors one could address. So one very concrete example here is one patient of mine. Let's call her Sarah. She's 57 years old and she gets referred by the cardiology department because of metabolic syndrome at first, because she's heavily obese. But she also presents with chronic pain syndrome, multiple food sensitivities, and chronic diarrhea. She has a mild depressive episode, and she also struggles with severe chronic sleep onset and maintenance insomnia. We also have had suspected back then obstructive sleep apnea syndrome. And what's very interesting in this patient of mine is that she had recurrent trauma-related nightmares, and she woke up every night having panic attacks and thinking about the car accident she was involved in with 20 years ago. And of course, she has a chronic stress burden and associated fatigue symptoms. So at first, because she was referred for metabolic syndrome, we talked about nutrition, physical activity, and so on, but we didn't see the changes we wanted, the effects we wanted. So what we actually did is we addressed sleep specifically, and here the turning point really came. So we worked on sleep structure and timing. We included rhythm stabilization and tailored evening routines. We also applied imagery rehearsal therapy to address her trauma-related nightmares. We screened for obstructive sleep apnea and actually treated it. And we implemented stress management techniques, especially mindfulness-based strategies. So cognitive behavioral therapy was a bit only partially effective, but then with addressing mindfulness-based techniques, she got a better grasp of her sleep behavior, but also of her pain syndromes. So she could really better regulate her awareness and pain intensity. So as her sleep improved, we saw a dramatic shift. Her mood stabilized, energy levels rose, and she engaged more confidently with movement and social contact. So in this case, sleep was not just a side pillar, so it was the key that unlocked the progress across all of these other lifestyle medicine domains. And I think that this integrated person-centered approach is really necessary to address such complex cases where patients present with multi-morbidities. So I will leave you with just a couple of take-home messages before I give over to my colleagues. I think that sleep is essential, not optional, within the framework of lifestyle medicine. So I think it's one of the most undervalued lifestyle medicine pillars, but I, in my clinical practice, experience it as one of the most influential. It interacts bidirectionally with all other pillars. I won't go through them again. And while research is still evolving, we know that sleep has the potential to be the catalyst for broader transformation in the lifestyle medicine sector. So I'm really happy about the symposium today, and I'm really excited to hear about all of the expertise that my colleagues will bring now in their following talks. So just to leave you with the impression, if you have more questions about our organization, please follow up to our website and get more information there. But without further ado, I will stop sharing my slides and give over to you, Dr. Yongyut Mayala.
Thank you very much, Dennis. A very informative talk and also very interesting clinical case as well. We may come back to you a bit later at the end for some questions. Let's move on to Dr. Narisha Chirakan Wasan, President of the Sleep Society of Thailand. She'll be talking about sleep and longevity. Dr. Narisha, are you online with us now? Please.
Yes.
Thank you.
Can you see my slide? Sorry, should go to the first.
Here it is.
All right. So thank you so much, Dr. Young, for a kind introduction and, very nice opening talk by Dr. Dennis Pfeiffer. And my talk will be about sleep and longevity. So this is the outline of my talk. I'll be talking about the importance of sleep, sleep duration and mortality, and common sleep disorders and health outcome. So the importance of sleep. So I would like to go very brief on the normal sleep architecture. So we're actually going through the non-REM 1, which is the lightest stage of sleep, usually around 2 to 5%. Non-REM 2, around 45 to 55%. And non-REM 3, or the deepest stage of sleep, or you may have heard, it's being called like slow wave sleep or restorative sleep. And that is usually around 20%. And the REM sleep, or the dreaming phase of sleep, is usually around 20 to 25%. And normal sleep efficiency should be greater than 85%. And why the sleep is actually important, because it actually involves, all the organ functions in the body. So sleep has been shown to be the stage of memory collection and also consolidation, particularly during REM sleep. Many studies demonstrated that adequate sleep enhances good memory, and sleep converts short-term memory into long-term memory. Sleep also increases work efficiency and reduces false memory. Adequate sleep may promote better immune function, as inadequate sleep has been shown to impair leukocyte function and immunoglobulin production. And inadequate sleep duration may be associated with poor response to vaccination. So you may have heard during the peak of COVID-19 that one of the recommendations prior to getting the vaccine is actually to get the adequate sleep the night prior to receiving the vaccination. Also, during sleep, heart rate becomes lower, and there is nocturnal dipping of the blood pressure due to vasodilatation. And that is very important for the cardiovascular health, meaning that if you don't have the nocturnal dipping of the blood pressure, then you have the increased risk of developing hypertension. Next, I'll be talking about sleep duration and mortality. So this is the figure from National Sleep Foundation. And this is the recommended sleep duration according to the age range. And you can see for the adult, the recommended sleep duration is around 7 to 9 hours for adults aged between 26 to 64 years old. And for the elderly population, the recommended sleep duration is around 7 to 8 hours. And if you are to pick just one number, it's very interesting that, the lowest mortality seems to fall around 7 hours of sleep. And this study has been pretty much similar in terms of the result, even from the Western study or Asian studies, that the lowest mortality seems to be at 7 hours. And you can see the U-shaped pattern, meaning that if you actually have increased sleep duration, usually more than 9 hours of sleep, you may have increase in the all-cause mortality. And also, if you have, lower sleep duration, less than 6 hours in some paper or less than 5.5 hours in some paper, you also have increase in the mortality. And not only the mortality, you also have increased risk of having the total cardiovascular diseases, coronary heart diseases, and also the development of stroke. And as previous speaker has mentioned about the pillar, of the lifestyle medicine, American Heart Association also developed the new Life Essential 8. And recently, they actually also included sleep in June 2028 as the 8th metric for measuring optimal heart and brain health. So sleep, now next to, having, good diet, getting adequate exercise, controlling blood sugar, and having the optimal weight, and reducing the lipid in your diet and control your lipid profile, having an optimal blood pressure and smoking cessation. So now the sleep is being recognized as one of the very important metrics. I would like to talk about this disease because it's very common. It's insufficient sleep syndrome. So in order to be diagnosed with insufficient sleep syndrome, you have to meet all of these 5 criteria. So A, the patient has daily periods of irrepressible need to sleep, or daily lapses into drowsiness of sleep, or in case of prenatal children, there's a complaint of behavioral abnormalities attributable to sleepiness. B, the patient's sleep time established by the personal or collateral history, sleep logs, or actigraphy, usually shorter than expected of age. And this is the example what the actigraphy looks like. It's like the wrist-worn device. You wear it on your non-dominant wrist, and you monitor your activities, and it can estimate your sleep duration. C, the curtailed sleep pattern is present on most days for at least 3 months. D, the patient curtails sleep time by such measures as an alarm clock or being wakened by another person, and generally sleeps longer when such measures are not used, such as on weekends or vacation. So if you have to wake up with the alarm clock, then you're not getting enough sleep. And also, if you sleep longer on your day off, usually more than 2 hours compared to your working days, then you may have insufficient sleep syndrome. E, extension of total sleep time result in the resolution of the symptoms of sleepiness. And the symptoms or signs are not better explained by other conditions. So sleep deprivation can lead to several health consequences. Through increase in inflammatory cytokines, leads to endothelial dysfunction, reduction in glucose tolerance, reduced renal salt fluid excretion and lipid cluster, and that can lead to metabolic disorder. Sleep deprivation can lead to increase in sympathetic activities and decreased parasympathetic activities, and that can lead to autonomic nervous system activation. And also it can suppress immune cells and can increase risk by developing the abnormal cytokines, and that can lead to immunity impairments. So all these can lead to cardiovascular diseases and increased risk of having infection. So short sleep duration has been demonstrated in systematic review and meta-analysis. In this study demonstrated that short sleep duration, less than 6 hours, is associated with increased risk of mortality, increased risk in the development of diabetes, hypertension, cardiovascular diseases, coronary artery diseases, and even obesity. And this study we conducted at our center, it was a prospective cross-sectional study performed on the young doctors less than 40 years of age at King Chulalongkorn Memorial Hospital in Bangkok, Thailand. I also did this study with my sleep fellow at the time, and she was from Malaysia. So we did 2 site studies. So another site was conducted at Hospital Kuala Lumpur. We used the questionnaire and the home sleep apnea testing. The primary objective of that study was to evaluate the prevalence of OSA. However, we actually found that the prevalence of sleep deprivation in this population was very high, 44%. Prevalence of excessive daytime sleepiness was 15%. And the prevalence of tiredness was 65%. And the prevalence of perception of inadequate sleep was 62%. Next, I will be talking about common sleep disorder and health outcome. So because limited time, I probably will be only talking about on one disease, which is the obstructive sleep apnea, one of the most common sleep disorders among the general population. So obstructive sleep apnea, you can see on the right side of your screen, is a repetitive upper airway obstruction during sleep, resulting in intermittent hypoxia and sleep fragmentation caused by arousals. You can see there was a collapsing of the upper airways, usually at oropharynx or hypopharynx, and that's occluded the airways, so your oxygen cannot go through your lungs. So what are the common presentations? So snoring is the most common presentation. However, the patients can present with excessive daytime sleepiness, observed apnea, choking or gasping for air, nocturia, cognitive impairment, or even insomnia, particularly in female. Sometimes female, they don't come with excessive daytime sleepiness. On the other hand, they may present it with insomnia, usually with sleep maintenance insomnia. They can also present it with morning headache as well. So you can see on this graph that increase in the severity of OSA indicated by higher apnea hypopnea index or AHI, reducing your survival. You can see the graph here, particularly when your AHI is greater than 30, indicating severe sleep apnea. Your survival is much lower than the normal control, the AHI less than 5. So currently, the gold standard treatment for obstructive sleep apnea is continuous positive airway pressure or CPAP. So this is how CPAP works. Because when you have obstructive sleep apnea, there is increase in critical pressure. That's the pressure that's trying to collapse your airways. So if you actually have CPAP, meaning you increase upstream pressure. So if you increase upstream pressure high enough, you should be able to bypass the obstruction. So the study has been shown that if you have adequate CPAP usage, you may reduce cardiovascular events, and you have to use it long enough. You can see on the left side, if you use it greater than 3 hours to cross 1, meaning it's not a significant reduction in the composite cardiovascular events. However, if you use the machine more than 4 hours or more than 5 hours, your hazard ratio is reduced. And the benefit was also even demonstrated in the elderly population. So this is an interesting study conducted on almost 1,000 elderly population greater than 65 years of age. And they followed the patient for 69 months. And compared with the control group, the fully adjusted hazard ratio for cardiovascular mortality were 2.25 for the untreated severe obstructive sleep apnea, 0.93 for the CPAP-treated group, and 1.38 for the untreated mild to moderate obstructive sleep apnea. And you can see in this figure that if you use the CPAP, if you treated them with CPAP, you have the reduction in mortality significantly. And this is our guidelines for obstructive sleep apnea. Sorry, it's in Thai, but we have brief summary towards the end in this book in English. So you can actually download this using the QR code or using, Google Translate or ChatGPT if you wish. We're going to have the new version coming up soon, potentially early next year. So in conclusion, sleep is an important stage controlling organ functions. Adequate sleep duration is essential. Recommended sleep duration for adults is 7 to 9 hours. Insufficient sleep syndrome is common and associated with many health consequences, including increase in mortality. Obstructive sleep apnea, particularly in severe groups, is linked to reduction in survival. CPAP is the first-line treatment for obstructive sleep apnea, and adequate CPAP usage, greater than 4 hours every night, was shown to be significantly reduced mortality even in the elderly population. So thank you very much for your attention, and these are my email, and you can see also the website of Sleep Society of Thailand. for your information.
Thank you very much, Dr.
Thank you very
Narisha.
much.
Thank you. Very comprehensive. And I'm a little bit worried about my sleep hours now. Need to be optimized at about 7 to 9
Yes.
hours. Yes.
Or at least you keep it more than 6 hours.
More than 6 hours. I remember that.
Yes,
Thank you
but
very
not more
much.
than 9 hours, please.
Thank you. Thank you, Dr. Narisha,
Thank
and
you
also
so
the
much.
Sleep Society of Thailand. Okay.
Thank you.
We may have some question for you a bit later on. Thank you.
Sure.
For the viewers at home, if you want to pose some questions, please put into the mailbox, and I'll try to read them out at the end for you. For the next speaker from Switzerland, we have Dr. Albrecht Wolster. He's director of the Swiss Sleep House Bern, and he will kindly deliver a talk titled, "What is good sleep and how do we measure it?" Dr. Wolster, please.
Yes, thank you very much for having me.
Thank you very much.
As we just heard, sleep is one of the big pillars of health among diet, exercise, social, and of course, substance abuse and stress. And if you look in a big epidemiological study, you can reduce your all-cause mortality by each of those pillars. And as Dennis nicely pointed out, they all interact with each other strongly. There's probably not a single process in our body that does not rely on sleep, neither in the brain nor in the immune function, metabolism, and cardiovascular system. If you want to read more about that, you can have a look in my latest review on the topic of sleep health that came out last year. Sleep problems are very frequent. They're actually about the most commonly reported symptoms in general physicians. And in Germany, in Switzerland, and in the US and other parts of the world, we have about 10% of the society that has insomnia, about 10 to 20% of the society that has sleep apnea, 7% restless leg syndrome, that's an urge to move the legs in the evening with unpleasant sensations. Then we have parasomnias like sleepwalkings, night terrors. And then we have nightmares that are 3%. And then I have not listed here excessive daytime sleepiness or circadian rhythm dysfunction. So this equals roughly to 20%, 20 to 30% of the society that is affected by a sleep disorder that needs medical treatment. Many people are affected by two sleep disorders at the same time. For example, 1/3 of people who have sleep apnea do have as well insomnia. It's called COMISA, comorbid insomnia and sleep apnea. So we should not always look for one single disorder of sleep, but sometimes several disorders at the same time. The big question of my talk is, how do we measure good sleep in the first hand? If a patient comes to you and asks you, "Please, doctor, tell me if my sleep is good or bad," and I would probably not recommend you to ask your watch and look at the body battery in the morning. So how is good sleep defined? And it has been only now 10 years since we discussed this question. And the first one who brought up this discussion was Daniel Bicey. People who are in the sleep field might know him. He invented the PSQI, the Pittsburgh Sleep Quality Index, that he does not like that much anymore. Anyway, so in 2014, he wrote this article, "Sleep Health, Can We Define It and Does It Matter?" And it started actually that he was sitting in a taxi with the president of the National Institute of Health in the USA. And that president said, "Well, you sleep guys, you're kind of strange, right? The blood pressure, the people who are for cardiovascular health, they have clearly boundaries for good cardiovascular health, like a real blood pressure, good body lipids. But you sleep people don't really have good measurable objective measures for sleep." So it left him troubled, and he came up at the beginning with 5 different domains of sleep. In order to have a good sleep, you have to have a good satisfaction that in the morning you feel rested. You should be alert during the day and not fall asleep while you're reading or working. Your sleep should be well timed. That's a problem in people who do shift work. It should be efficient, so you should not lay awake a lot of time during the night, so you should not have insomnia. The duration should be adequate, as it was just addressed, between 6 and 8 hours, if you look at the boundaries of all-cause mortality. And 1 year later, he found, well, I missed as well sleep regularity. Sleep should be more or less the same time. Like good nutrition should be more or less timed good for our body. As sleep is tightly connected to circadian rhythm. You can remember those 6 different pillars that are the core pillars of sleep health by the acronym RU-SATED. And all of them are not directly disease related. Of course, you can have more example, for example, good regularity. However, you have a low satisfaction. Your alertness during the day is very poor. Your timing is good. Your efficiency is very poor, and your duration is high. So you can be on all of those domains. You can be good or bad, and it does not mean that you have to have a sleep disorder if you're poor in all of them. So it means just your risk or susceptibility to develop a sleep disorder in the future. So those 6 pillars are really to measure how is your health layout for sleep. And they, as you see at the end, they all give you recommendations what to do if one of those pillars fall into a non-positive side. So sleep health is a multidimensional pattern of sleep and wakefulness that promotes physical and mental well-being. So it's not just one single metric like duration or regularity. You have to combine those duration. It's like with vascular, you need a good heart rate and you need a good blood pressure and a good endothelial health. And you combine those measures into cardiovascular health, of course. And that it makes sense to combine those measures, you can find in several studies that have been done with the UK Biobank. In 2019, the group of Lou Key, he works in the US, came up with a healthy sleep score, and he had 5 sleep factors: early chronotype, a sleep between 7 and 8 hours, rarely insomnia, so a good sleep efficiency, no self-reported snoring, and no frequent daytime sleepiness. And he found that people who scored positively on all of those 5 items, they showed a higher risk of stroke, reduced by 34%, a lower risk for chronic heart disease, and lower risk for cardiovascular disease. And you can find nowadays studies on cancer, depression, diabetes. You can find for all of them that those compiled scores give you a risk reduction. We found that in our clinic as well, and we made a sleep burden index, so that just turning the whole concept around, and we found that if people who had a stroke at the stroke unit did not or had a good sleep duration, did not have insomnia, no sleep apnea severity, and no restless legs, that they had a strongly reduced relapse for stroke or other cardiovascular events the 2 years after stroke. And it was about in the same range as putting them on hypertension medication during the same time. So in every stroke patient, every cardiologist would closely look for a hypertension treatment, and it looks like we should as closely look as good sleep health in people who had a stroke or heart attack. There are evidence for the different health dimensions, and I'll quickly show you some of the very good papers that are out there. For example, all-cause mortalities and sleep duration has been shown, and I really want to point out that long sleep durations are higher correlated to higher mortality. So it's worse to have 9 hours than having just 5 hours of sleep. So we should focus more on overly long bedtimes than on the short bedtimes. The prevalence of insufficient sleep syndrome in the population is only about 5%. Of insomnia that is usually brought to us by long bed durations, we have about 10%. So we should really look at the long sleepers, not too much on the very short sleepers. the efficiency is a much stronger predictor for stroke, like in having insomnia, than the total sleep duration. You can have here a very nice study by Wallace et al., a very outstanding epidemiologist in the terms of sleep health, and you find that sleep efficiency here is has a higher component effect as sleep duration that is down below at the lowest part. Yeah, don't look too much at sleep duration. Look at the other factors of sleep health. Here we have that efficiency and the effects on dementia, and you can see that efficiency is a high risk factor for dementia, but as well breathing, like in sleep apnea, and excessive daytime sleepiness. So not too much duration. Actually, we do find in studies that overly long sleep duration is more associated with mild cognitive disorder. Insomnia, so that's overly long bedtimes, is a strong risk factor for depression, anxiety, and psychiatric disorders, as found in this very nice overview here. I have to okay. And very interesting, this paper from last year by Windert et al., they found that sleep regularity was a stronger predictor of mortality risk than sleep duration. And again, they used the UK Biobank, and that has more than 400,000 people in the cohort, and they found that, that the regularity is really the key. And you see here in red, the people with a very poor sleep regularity, that they have a much lower probability of surviving. Yeah, so we should rather look for the other dimension of sleep health than just looking at sleep duration, which is the poorest of all factors of the sleep health. One domain that has not been listed so far, but we should discuss, and this discussion is not done so far, is light exposure. The group of Burns et al., they found that the time spent outdoor of lighting is associated with mood, sleep, circadian rhythm outcomes, and in a cross-sectional longitudinal study over 400,000 participants of the UK Biobank. And they found that each additional hour spent outdoors was associated with lower odds of lifetime major depressive disorder, antidepressant usage, less frequent anhedonia, greater happiness, and lower neuroticism. Yes, so keeping a stable circadian rhythm has not been so far has been neglected during the last year so much because we don't measure it regularly. Thankfully, in the UK Biobank, they had wrist watches that they gave out, and so they measured that. But I believe that we are highly undervalue the effect of lighting. So in our review, we came up with at least 8 domains of good sleep. So not just the are you sated, but I think and other studies have shown it that good breathing is overly important, and this is so far not covered by the are you sated. There is no good breathing included. And I think there are as well some sleep disorders that are not included in just regularity, for example, nightmares or restless leg syndrome. And we know that restless leg syndrome can reduce your health. We can come up with good recommendation for the population. For example, duration, we can suggest 6 to 8 hours of sleep. And please, we have to rely here on the epidemiological studies, not just what has been generally concluded. The 9 hours are worse than 8 hours. We should, for the efficiency, we should restrict the time in bed to the average sleep duration. So not staying longer in bed than you have slept for the last 2 weeks. We have to treat the causes of daytime sleepiness. That might be sleep insufficiency, but most often it's sleep apnea, or we should treat snoring and sleep-related breathing disorders. They are highly prevalent. We should treat restless legs with sufficient iron, nightmare disorders, and with imagery rehearsal therapy. We should and people should go to bed and get up at the same time, more or less 30 plus minus 30 minutes, and sleep at night according to our chronotype. And we should seek help if people do not feel refreshed. So there are easy recommendations that you can take from each of the pillars of sleep health. So how do we measure sleep health? BICE proposed a very easy questionnaire, and it's actually not that poor, not that of a problem to use this questionnaire, because it has been used, for example, more or less in the UK Biobank, and you can see clear correlation with you just using a questionnaire. We have developed our own questionnaire that is published, the Burney Sleep Health Questionnaire, which serves on the one side to evaluate the sleep health and additionally to evaluate if there is a sleep disorder. And from that questionnaire, you can look if the sleep duration is good, if how the chronotype is, how is there snoring, daytime sleepiness, insomnia, and set a good satisfaction. So it's a very easy questionnaire, and I would be happy if would be translated in Thai. I can easily give you all of them. You have translated in German, English, French, and Italian so far. We can measure sleep health very well by actigraphy. So with alertness, you can measure by the minutes of napping, the duration by the total sleep time, the timing by the midpoint of between sleep onset and offset, the sleep efficiency by sleep maintenance, and the regularity by the midnight or by the sleep regularity index. So we can in future actually compute a sleep health by Fitbit. We can use as well bed sensors like the Withings sleep analyzer, but there are others out there, because we can detect with them breathing rate, heart rate, movement, and snoring. And with that, again, we can calculate duration, timing, breathing, efficiency, disorders, and regularity. Yeah, and they are very low cost. Such a sleep tracking sensor costs about 20 to 30 euros for the manufacturer. So I think in the future, next 10 years, this will be built in every bed. This is what an output of that looks. You can see a very clear sleep diary with regularity, wake in bed and outside of bed, and you can get a clearly picture for long-term monitoring of your patients, and as well about their snoring and their AHI just using such a mattress sensor. Again, you can look at 5 of those big pillars. However, in the next years, we'll have a phone-based sensor that will come up because if you glue your phone for several nights on your chest, you can measure the time you spent in bed, the timing when you went to bed, the sleep efficiency, regularity, your snoring by the tone. It can record your heartbeat. So I believe that our screening for sleep disorders in the next 5 years will be through wearing our smartphone for once a year for a week on our chest and sleep with that for several nights. Will be a very good. And the company that is producing this is called Apnea. The polysomnography, the nowadays gold standard, I think is not giving us all the good domains of sleep health, because it might might collect duration, but not the average duration. It might collect efficiency, but not the average efficiency during normal sleep days. The breathing will collect very well, but it will not collect your timing, regularity, and satisfaction. So I sum up. Sleep health impacts brain and general health as strongly as physical activity. Sleep health is multidimensional and cannot be measured purely by a single factor as sleep duration. Sleep health can easily be assessed via a questionnaire and or actigraphy, and in the future very well by bed sensors. They are already available. The different domains can be targeted by different behavioral interventions, for example, treat snoring or go regularly to bed. And there is an urgent need to integrate screening for sleep health in clinics and public as regular as blood pressure and screening. Thank you very much.
Thank you very much. Thank you very much, Dr. Albrecht Wolster. Our association would like to take up your offer of, your kind offer of the questionnaire. We'll translate that into Thai. It's very kind of you. And I look forward to this phone-based bed sensor. That's very new. Is it coming
Yeah,
out
it's
on
based
the
by
market soon?
Withings. It's outside already. It's by the company Withings. It's former Nokia, and they had very good knowledge in sensors. And it's in Europe, all over Europe, you can buy it. So it's probably shipped, and in US as well. And it already has tools to integrate with a physician. So you can probably buy it in Thailand via Amazon.
Oh, okay. We've been telling our patients to keep our mobile phone outside for charging, outside the bedroom. So we have to ask them
Oh, I
to
do
come
recommend
bring it
that as well, but not for the 1 week where we are measuring, or for the 2 weeks.
back. Okay. Thank you very much. We may have some question for you later on. Thank you. We shall now move on to the next speaker, and she's a psychologist, specialist in the mindfulness-based cognitive therapy, Dr. Thanita Watprasong. Her talk today is titled "The Science of Mindfulness for Better Sleep." Dr. Thanita, please.
Thank you very much. So let me share my slide. Okay. So, do you see my slide? I hope so. Thank you very much. So, good evening from Bangkok. And thank you very much, Dr. Yongyut, for a kind introduction for me. My name is Dr. Thanita Watprasong, and my colleagues call me Dr. Nun. It's been my honor to have a chance to talk about mindfulness and sleep for tonight. So, before we talking about mindfulness, it's very important that be aware that mindfulness is the ancient knowledge that exists here for more than 2,500 years already. So there's various aspects that we can talk about. And I aware of the time, I have 15 minutes here. So the topic that I'm gonna talk about is gonna relate it with my work. I'm a psychologist with a certified mindfulness-based cognitive therapy. So I'm gonna talk about the science of mindfulness and mindfulness-based intervention for better sleep, especially for insomnia. So let's start. Okay. So I'm gonna start with a question. What is mindfulness? And the invitation for you is to take a look at this video.
How much of your day is spent on autopilot, doing things without actually being aware that you're doing things? In the shower, do you feel the water splashing over your body, or is your mind somewhere completely different? When you're eating, do you actually taste the food? Walking down the street, do you see and hear what's going on around you? Or are you lost in your thoughts? So often we sleepwalk through our life on autopilot, without being fully awake to what is actually happening. Mindfulness expert John Kabat-Zinn once said, "Mindfulness is being alive and knowing it." It's about noticing the small details of our experience, things we would normally rush past, connecting us with the raw experience of each moment as it happens. When we do this, life feels brighter and fresher.
And that is mindfulness. So basically, mindfulness is you becoming aware of anything at all that you experience right here and right now as a human. So let's take a look here at the definition of mindfulness from Williams, Tisdale, Siegel, and Kabat-Zinn in 2007. So mindfulness is paying attention on purpose in this present moment and non-judgmentally to anything that there arises. And mindfulness is the traitability. What's that mean? It means that we as human, we were born with that. I don't know whether you notice or not, but we're born with the ability to being aware of this present moment right here, right now, non-judgmentally. And how we can access and even enhance this national capacity is through a practice. And you might familiar with the word meditation.
And that's how we use meditation practice to enhance this ability. So when you think about meditation, you might be familiar with this. It's the sitting meditation, maybe eye closed and you becoming aware anything at all that arising, maybe the thoughts, emotions, body sensation, or impulses. And that what we call formal meditation. And there's also another kind of meditation, which is we call informal practice. So it's means that you can practice mindfulness even in everyday routine. For example, you're having a shower and then you intentionally paying attention on the water that go past your skin, and maybe the sense of temperature like warm, the cold, or even tingling sensation on your skin. And that's how you also practice mindfulness. So you can see that there's various opportunity for us to practice mindfulness. And I'd like you to take a look at this graph, and you can see that mindfulness in academic journal is growing rapidly, especially after the year 2020 during the COVID time. So the topic is quite popular in the research area. And how mindfulness is related with sleep. This is another invitation for you to pause and then just bring back the memory of the night that maybe it's a little bit challenging for you to sleep. And maybe ask yourself, what is the sleep disruptor for you? And then keep that in mind, and let's see whether it's the same as the result from this survey study or not. So this is survey study in 2011. So people reported that things that keep them awake is in their head. What's that mean? It means because of the fears and worries and mental activity around work and school that keep them awake in bed and hard for them to fall asleep. And then what do people do? This is very, very interesting. So even they're aware that things in their head keep them awake, but the first thing that they do, they control the temperature right away. They're like, oh, maybe because it's too cold, so I'm gonna adjust the temperature. Or maybe it's the light, too much light. So I'm gonna put the bifold. So that's how they control external factor around them. I think it's interesting because for us as human, it's much easier for us to control external environment rather than manage our internal state, which mindfulness can help us handle and also responding skillfully to this kind of internal state. And you can see here, mindfulness also reported that a kind of meditation, which is people use for relaxation techniques as well. But what we're going to talk today is not about using meditation as a relaxation technique. We're going to talk about mindfulness-based intervention, which can help people with clinical conditions. So we're going to talk about mindfulness-based interventions. Where does mindfulness-based intervention fit? So you might already know that the gold standard of the therapy of insomnia is CBTI, which CBTI gonna fall in the first wave and also the second wave of psychotherapy here. And the result of CBTI is very promising since it's showing around 30% to 40% of patients achieve full remission. So why we still need the mindfulness-based intervention then? The thing is, when we take a look at people who experience relapse in insomnia, so they kind of show the elevations in pre-sleep arousal at the end of the treatment of CBTI, and that after that they experience the relapse in insomnia. So mindfulness-based interventions kind of directly address this arousal dysregulation. So mindfulness-based intervention kind of fall into this third wave of the psychotherapy here. And the most study of mindfulness-based intervention is mindfulness-based stress reduction, or MBSR. Another intervention is called mindfulness-based cognitive therapy, which mindfulness cognitive MBCT kind of different from MBSR in the sense that MBCT using the background of MBSR and also combining the knowledge of cognitive behavioral therapy as well. There's also another kind of mindfulness-based intervention that developed only for insomnia, which is called mindfulness-based therapy for insomnia, or MBTI here. Let's take a look at the structure of MBTI. So you can see that there's 8 weeks course, and you can see the red underline here. MBTI developed based on the background of MBCT and MBSR, and also combining the psychoeducation related with sleep according to CBTI. So you can see that there's psychoeducation elements for each week. And to make you be more familiar with the setting of mindfulness-based intervention, this is the 8-week course of MBCT, or mindfulness-based cognitive therapy, as the name suggests. And I also mentioned already that MBCT kind of combine the mindfulness practice with cognitive behavioral therapy. So there's 8 weeks course, and each week they're going to have specific theme for the week, and also the cognitive exercise for the week as well. So clients gonna work through their experience in a group-based setting for 2 or 2.5 hours per session. Then let's go deeper in the mechanism of mindfulness-based intervention. How does it work? This is the metacognitive model of insomnia. So there's 2 levels of arousals here. The first one we call primary arousals, which, to make it simple, is the thoughts that keep you awake. So basically, people with insomnia kind of have expectation about sleep, like I need 8 hours of sleep. Or maybe they kind of have daytime consequences of sleep loss, like tomorrow I have very, very important job to do. How about I don't have enough sleep tonight? Tomorrow gonna be disaster. And that's how it's increased mental activity in bed. And it's harder for them to fall asleep. And then it impacts the secondary arousal here, which is called metacognition, or the nickname for that is thinking about thinking. And basically, it's not only how you think about your thoughts, it's how you relate it with your thought. So people with insomnia, they tend to have very high attachment to their thoughts, to the primary arousal here. They truly believe that it's true, and they're stuck with that. So that's how it's hard for them to fall asleep. So how mindfulness helps? Mindfulness will not 100% eliminate the primary arousal here. Why I say that? Because we are human. It's quite common for us that we have mental activity. We have thoughts, we have feelings, we have emotions, we have everything as a human. So mindfulness kind of help us being aware of the primary arousal here, and then reduce the secondary arousal by help us letting go of the attachment of our thoughts. And then you see the arrow here. That's how we reduce the primary arousal, and that's how it decreased mental activity in bed. And then sleep comes naturally. So to make us go deeper into the metacognitive process and understand more, I'm going to talk about the 3 stages of the metacognitive process, which people who practice mindfulness and also joining the mindfulness-based intervention, they're going to start to the stage 1, which is called metacognitive awareness. So basically, it means they're pausing and then becoming aware of what is here right now, that they lying down awake in bed. Maybe the sensation of the body, like the heart pumping very fast, because it's hard for them to go sleep, and then they really try so hard to fall asleep. Or maybe they're aware of their thoughts or emotions or anything at all at that state. And normally what they do, they tend to react. They will try harder and harder to fall asleep. And the result, quite opposite actually. The harder you try, the less likely you will succeed. So people who practice gonna go to the second stage, which is called metacognitive shifting. So instead of they react with this stage, they're responding skillfully. They accept the first stage. For example, if they are aware of the anxious thoughts in the first stage, and then with the practice, they can respond like, I don't have to fix anything right now. I can just breathe in this moment. And that's how they ease their body and mind. And then maybe they become more likely to sleep. And then with practice, they will go to the third stage, which is so-called new metacognitive steps. When I say with practice, it means mindfulness is not a quick fix. So you're going to put time and effort to practice it. And then once you enter this stage, you're going to have your new way to respond to insomnia, which is you're going to let go of the attachment of having more sleep. You will have more flexibility around the situation that you're still lying down in bed. And this third stage is very important, especially for people who are experiencing relapse in insomnia. It's going to help in long-term remission of insomnia. I'm aware of the time now. I'm going to talk about it briefly. The question is, does mindfulness-based intervention really help? I would say from the research is yes. So take a look at here. It's the research in 2014. So they kind of combined people into three groups. There are two groups of mindfulness-based interventions, which is MBSR and MBTI. And you might remember that MBTI kind of also combine the psychoeducation related with sleep as well. So even though both of them are mindfulness-based intervention, but the process is quite different. And also comparing with the control group. And the result was quite promising here. The awake time dropped 43 minutes with both of mindfulness group. And both of mindfulness group achieved 38 to 50% remission rate within 3 to 6 months. Fascinating. There's also another study in the same year. They're comparing MBSR and gold standard treatment, which is CBTI, in the cancer patient population. So it turned out that at the end of the intervention, CBTI kind of work like more superior comparing to MBSR. But after 3 months of follow-up, MBSR just as work as CBTI as the gold standard. So we could say that MBSR kind of help in long-term emotional and sleep benefit. And this is the study a year later, comparing MBSR group and also people who taking medication for sleep. So the result turned out that MBSR group fell asleep faster, 8.9 minutes. So what that means? It means that we can use mindfulness-based intervention as the alternative therapy for medication. And this is the meta-analysis. I'd like to say that there's various kind of mindfulness-based intervention that you can choose from, and it's effective. But however, I'd like to point out here, this is the basic mindfulness meditation, which means the self-guided practice without therapists and without structured support. It seems like it didn't very effective for people who have common mental disorders. In this case, it's depressive symptom and also anxiety. So it might be a better idea if you having clinical conditions, then to seek help from professional and maybe finding mindfulness-based intervention that are available in your area. But if you don't have any clinical condition, you don't have depression, you don't have anxiety, that's fine. You can use meditation as one of the relaxation techniques for you if it helps you to fall asleep better. So I like to end here. Mindfulness won't knock you out like a sleeping pill. It helps you change your relationship with insomnia from panic to patience, from fixing to accepting, and from reacting to responding skillfully. Thank you very much for your time.
Thank you very much, Dr. Tanita, for your very comprehensive lecture, particularly on the mindfulness-based intervention. Very useful, very, very beneficial. Thank you very much. There are some questions waiting for you to answer at the end as well. We shall now have the honor of listening to the lecture by Professor Dr. Jon Rush, Chair of Swiss Sleep Network. He will kindly deliver a lecture titled Insomnia in Switzerland. Dr. Jon, please.
Yes, hello. Thank you
Hello.
very much
Thank you.
for the invitation. So now I think you should see me. Do you see my slides? Is that fine? Great. So first, thank you very much to the organizers of this symposium to invite me to speak here. I think it's a great opportunity, also as it's such an intercultural endeavor to talk about sleep. I think this is a very nice idea. Thank you very much. And I'm professor of psychology here. I'm doing sleep research since over 20 years. And my main research area was actually memory and sleep. I did a lot of research on targeted memory reactivation. And in the last years, I focused more on the problem or on the question, so how do thoughts and ruminations, as we just heard in the previous talk, how do they actually influence our sleep? So I could present you a lot of studies, but I thought maybe in this opportunity, it's actually also a good idea to look at other influences on sleep. And this could be, for example, cultural influences on sleep. And I'm a professor here in Fribourg. So as you might know, you maybe want to learn also something about Switzerland. Switzerland is a country with a lot of different languages spoken, which is of course also the case in other countries. But here you have, in my city at least, really a bilingual city. So you have a large French-speaking population and also a German-speaking population. And there's also an Italian-speaking population in Switzerland, and even a fourth official language, which actually I don't know how to say that in English, Romanian or something like that. It's not so common. But so I thought to introduce you to differences in sleep based on these language regions. And I would just shortly start just to remind you what insomnia is. So insomnia is a sleep disorder that is diagnosed with subjective measures. So we don't need any sleep laboratory for this. So it's more a subjective evaluation of our sleep satisfaction and our feelings, how we slept. So do we have difficulties to fall asleep, or do we have difficulties of remain asleep during the night? Or, for example, this very common sensation that you wake up too early and that you have difficulties to go back to your sleep. Importantly, to diagnose insomnia, there's also a need that this problem or these problems of falling asleep have daytime consequences. So that means that you really feel fatigue or sleepiness during the day, you have difficulty concentrating or paying attention, recalling memory, you have emotional distress, and so on. There can be even more factors, and there needs to be a certain duration or frequency, so at least 3 times per week or more than 3 months. Differs a little bit depending on what manual you're taking. So when you look at this insomnia diagnosis, you can of course ask, so how often or how many people have insomnia? We already heard some numbers in the previous talks. Actually, if you look at the literature, the variation is actually quite big, depending on this study. Partially, this is due to the question, how do you actually diagnose it? So do you, for example, ask for the daytime consequences? Do you not ask for the daytime consequences? So, of course, there's sometimes different ways of diagnosing it or including the subjects, but there's a clear pattern. For example, you have increases of insomnia diagnosis with age. You have a higher risk of female having insomnia as compared to male. So I think that is, we find in almost all data. But coming to the topic of my talk, actually, when you look at this table here, which was published by Dieter Riemann in 2017 in his guidelines for insomnia, then you can see these prevalences based on the different countries in Europe. So it's only focused on Europe, unfortunately. So you can see that the samples are quite big, and the different studies report kind of different insomnia diagnosis percentages. And for example, when you now focus on the countries in question, so you have, for example, France, who has 19% of having an insomnia diagnosis. This appears quite large, actually, is much higher than the numbers we usually read. And then, for example, you see Germany here, that only have a 5%, on here Italy with 7%. So again, this could be due to different diagnostic criteria. But so one question we wanted to ask is, so what happens if all, maybe it has to do something with the culture and the language you speak. So we wanted to take the opportunity to look at Switzerland, where actually French-speaking people and German-speaking people live in the same country, and also Italian-speaking people live in the same country. So it's actually much closer together, I would say. So this is Switzerland. Maybe so you learned something about Switzerland today as well. So this is Switzerland. You have Geneva here as a big city. You have Zurich around here as a big city. Actually, the capital of Switzerland is Bern. That's like here in the middle somewhere. Fribourg is I think here somewhere. So there's no cities on this map, but what you can see is the language regions. So you have a large German-speaking language region, which is here in red, and you have a French-speaking language region, which is here in, what is that? Blue, violet, something. And then you have the green region here. This is Italian-speaking. So Italy would come here afterwards. And then you have some yellow spots where this Rhaeto-Romanian language is spoken. That's more in the really mountainside of Switzerland. So do these people have the same reports of sleep complaints? Was the simple question. What we used to answer this question was data from the Federal Office of Public Health. They do a representative survey of over 20,000 participants each every 5 years. They do that since 1992. So there's really a good database, I would say. The problem is that the question they ask is not an insomnia question. That's why I changed the title of my talk to sleeping problems and not insomnia in Switzerland, because it's clear with this questionnaire, there's no diagnosed insomnia. It's just the question, did you have difficulties falling asleep or staying asleep? Which is at least close to the sleep symptoms of insomnia. If you're interested in this data, you can also use these links. It's unfortunately only in German and French, but there's you can basically play around. They have some visualization of this data available. And I will just show you some small spots on this visualization. For example, this is the data from 2022. And here you have color-coded the different percentages of sleep problems in Switzerland, and the darker the blue gets, the more sleep problems are reported. For example, the highest proportion is between 41 to 42%. Again, this is, as is clear, this is not insomnia diagnosis. This is really reported sleep problems. So we have a lot of medium severe sleep problems here. So the proportion of insomnia will be much smaller. But still, it's very interesting to see the pattern in Switzerland, because there is a clear pattern. So please ignore the white. There's just not enough data, if I understand this survey correctly. But if you look at the shades of blue, then you see that the darker blue is always in this region here, and the lighter blue is in these regions. And here you have a list of all the cantons. These are small regions in Switzerland. And you see the darker blues, they are all French-speaking, and the lighter it gets, they are all German-speaking, basically. And the Italian-speaking is here, Tessin, that is in the at the higher end. So this is a curious pattern that basically in the French-speaking countries, not countries, cantons, the reported sleep problems are just much higher. And so now you could say, okay, this is just in this year, it's just by chance. But so when you look along the years, it's actually always the same. So it's very stable pattern. And when you look at it longitudinally, so this is so the darker here, so this color here, this is the German-speaking sleep problems, and this is here the Italian and the French-speaking sleep problems. So that you see that the percentages are always higher since 25 years, or the years since 20 years in the French-speaking and Italian-speaking regions. And here you see only the numbers of the medium severe sleeping problems. So the high sleeping problems are not included in this graph. So now the question is, of course, what is the explanation for this difference? And unfortunately, I cannot tell you, because we are looking for explanations, and we controlled for age, we controlled for gender, we controlled for socioeconomic status, we controlled for education, we controlled even for living context. So you could say that the architecture or the dense of the population is different, but nothing really gets rid of this difference. And this is kind of curious, especially in Switzerland. Here's another graph that illustrates this higher percentages in the French-speaking and the Italian-speaking regions. What I separated here is also the more severe sleep problems. And that's actually interesting that there suddenly the regional differences are kind of gone. So maybe if you really do a strict insomnia diagnosis, you get maybe a little bit rid of these difficulties. But in this medium range, you have really a high regional diversity. And again, the question is, why is that the case? Is that just by chance? This is actually very unlikely, because it's very, very stable. It's always the same question. But then we come to the interesting parts. Maybe people understand the question differently. That could be so in the different languages. It could be just that the same question is understood differently. But it could also be that maybe the severity or the look at your sleep is different depending on the culture. And there, of course, we come to very interesting aspects that we already heard in the previous talk. It's, of course, how do you conceptualize good sleep? How do you conceptualize bad sleep? What do you know about sleep? What are your expectations on sleep? And so forth. So this, of course, could have a big influence. But, of course, there could also be a general difference. So it could also be a real difference that actually people sleep differently depending on their culture. And one hint that this could be a real difference is also when you look at hypnotic drug use across Switzerland. And there you actually, if you look at it, it's of course, you don't look at I mean, I can explain you what the color means. So, for example, the red line is the hypnotic drug use depending on the age. Of course, it increases by age. But the red line is, for example, Geneva, which is French-speaking. The yellow one is Tessin, which is Italian-speaking. This is also French-speaking here. Fribourg, that's the canton where I live here. It's also here. And then you have the German-speaking cantons down there. So, is that real? Is that really more sleep problems in these French-speaking and Italian-speaking areas or not? Or is also the culture of giving hypnotic drugs by the doctors different? Of course, there could also be a culture of assigning drugs more easily in some culture or not. But for me, at least, this is a very curious problem. And I just have to leave you with this observation about Switzerland. I don't have any explanation, but I think it's really worth exploring, because it could tell us more also about the perception of sleep, also about factors that cause more or less insomnia and insomnia problems, to more investigate these regional differences. Just to summarize, so we can, since 25 years, see that we have higher reported sleep problems in French and Italian-speaking language regions, even if you control for many, many factors. We have a similar pattern for hypnotic drug use, and the biggest effects are not for the insomnia or very pathological sleep problems, but more in the medium severe sleeping problems. And it fits with the prevalence rates that are reported in other countries that are only French-speaking or only German-speaking. So actually, there's an interesting question there that we need to answer. Just as so here in Switzerland, we have now funded this Sleep Network Switzerland. We're also trying to work both the French-speaking region and the German-speaking region, and ideally also the Italian-speaking regions together on this question on sleep, because it's true, these cultures also are, from the research side, sometimes a little bit separate. And so we are trying to do this and basically give more information about sleep, and also, thanks to Albrecht Forster, offer sleep tests that people can use since March 2025. This is now online in German and French language, and since then over 3,000 people have used this sleep test. It's based on the concept of sleep health that Albrecht introduced just right now, and we can see so here's even a link if you to. It's not in English yet, but we want to do that as well. And we can see that really many people use this test, even from all age ranges, basically. So I think also if you want to translate that to your language, I think this will be a very useful tool for different societies. Just as a last note, if you look at these data, you of course can look at different aspects in this data, because it's always the same question. What you can see here, for example, one interesting thing, there's always this idea sleep problems increase drastically in the last years. In a way, they do a little bit, but not so strongly as it's usually seen in the literature. At least the sleeping problems are roughly around 30 to 40% in the last 25 years. We see an increase in the younger age range that's even more pronounced if you would reduce it to only females. So there you really, in the last 5 years, you have an increase in sleep problems. I think this is an area that is really a big problem for our society. But the funny thing is that I also wanted, or not funny, but the nice thing that I also wanted to show that you don't talk about it much, at least in Switzerland, you had also an improvement in sleep satisfaction, especially for the older generation. That's actually also, for me, a quite interesting point. Thank you very much for your attention, and thank you very much for your invitation to the symposium.
Thank you very much, Professor Rush. It's very interesting to look at Thailand, because we have various regions and people having different languages and different cultures as well. So maybe the same sort of sleeping problems, differences may happen in Thailand too. May look at that later on. Thank you very much indeed. Thank you. And now let me conclude this evening presentation with my talk, which is on the microsleep and road traffic accidents. And I would like to give credit to Dr. Param Dali, lecture titled A Key for Lifestyle Medicine, delivered online by Harvard University in 2024 for some of the information I'm about to present to you this evening. Now, over the past months, several people have asked me why is the Thai Lifestyle Medicine and Wellbeing Association placing such a strong focus on sleep health and the dangers of sleep deprivation. To me, the answer is quite simple, but it's deeply concerning, because the true toll of lives lost due to microsleep remains vastly underreported and poorly understood. Now, unlike alcohol-related accidents where we have clear data and we have the processing and the laws as well, law enforcement, the impact of drowsiness and fatigue behind the wheel is far harder to measure and often goes unnoticed. Drowsy driving is a silent threat, and there are no breathalyzer for sleep deprivation, and there are no roadside tests to detect exhaustion, and yet it poses just as deadly a risk. Now, without reliable statistics, public awareness campaigns struggle to gain momentum, and lifestyle changes are hard to materialize, are hard to motivate. Now, the next slide, we show the subtle warning signs of sleep deprivation, many of which are brushed aside or even normalized. Dozing off during meeting, nodding off while waiting at the red light, it happened to me once too, or proudly claiming, I function just fine on minimal sleep. These are not signs of strength, but in fact they are red flags. Sleepiness itself may not kill you, but falling asleep behind the wheel can. Research shows that being awake for 16 hours or getting only about 6 hours of sleep can impair your driving performance as much as having a blood alcohol level of 0.05%. Now that's frightening comparison. Credit goes to Williamson, published in Occupational Environment Medicine Journal, the year 2000. And tonight we hope that we all leave with a renewed understanding of how crucial sleep is, not just for our own well-being, but also for the safety of everyone around us. Research showed that if you go without sleep for 3 days, your number of errors could peak at around 15, 16. Surprisingly, if you limit your sleep to just 4 hours per night for 14 consecutive days, your error rate will be just as high as someone who has not slept at all for 3 days. Now, this is according to Von Dongen, Clinical Sport Medicine Journal of 2004. According to the Department of Highways of Thailand, the road accident data from May 2025 revealed that 67% of accidents were caused by speeding beyond the legal limit, but 9% were due to drivers falling asleep, and 6% resulted from close-range cutoffs. However, I believe that these figures may not fully reflect the true causes. Some incidents labeled as close-range cutoffs could actually stem from microsleep episodes or suddenly waking up from microsleep and have a sudden reaction and lose control of your vehicle, for instance. Now, these are the routes prone to drowsy driving. 8 key routes in Thailand where accidents were believed to be caused by drowsiness and microsleep. Now, take a look at the highway number 4 and number 402 heading south of Thailand, and both contain long, straight stretches of road up to 10 kilometers with minimal external stimuli. Such monotonous routes can make driving feel effortless and may induce drowsiness too. Monotony, microsleep, and highway hypnosis. Now, this is important issues. These roads offer low cognitive stimulation, and drivers don't need to make many decisions or don't have to frequently adjust the steering wheel. So over time, this can lead to microsleep, which are short episodes, about 3 to 14 seconds, where the theta waves temporarily replace the normal waking alpha rhythm, as seen on the EEG recordings. Prolonged monotony can lead to highway hypnosis. This is also known as white line fever. It's a mental state where drivers operate a vehicle over long distances without consciously remembering doing so. Now, this is sort of trance-like state. Attention is diverted elsewhere, but the brain still continues to process the road and the vehicle data subconsciously. Now, this phenomenon reflects automaticity, where complex tasks are performed with little conscious awareness. Now, 2 experiments reported by Oron Gilad and colleagues explore how different road types affect the driver fatigue during extended simulated drives. Experiment 1, they have the 10 military truck drivers navigated a mixed route consisting of straight, winding, and straight highway segments. Experiment 2, 16 additional drivers were each assigned to one of the 3 road types, straight, winding, or mixed. Now, fatigue symptoms were assessed using the performance measures and subjective self-reports, and also the psychophysiological data, including the heart rate variability. And the key findings were that the fatigue-related decline in driving performance varied by road type. On the straight roads, now we observe the decline in lane keeping quality, reduced steering precision, and the decreased longitudinal speed. On the winding roads, drivers tended to increase their speed over time, but the lane keeping did not deteriorate significantly. There was a brainwave studies reported by Hong Oh and colleagues further supported that driving on straight versus winding roads generates different levels of brain activity, reflecting varying states of alertness and drowsiness. However, research has yet to determine which road types is more prone to inducing microsleep episodes. Now, in a significant study led by Dr. Manoon Leechaweng-Wong and colleagues, researchers examined the link between drowsiness and traffic accident among commercial drivers. 4,331 commercial bus and truck drivers completed a self-administered questionnaire, and the results show that 69% of drivers had experienced at least one accident. Of these, 1/3 were attributed directly to drowsiness. 75% reported episode of drowsy driving, and 28% had experienced microsleeps. Primary causes of drowsiness include the sleep deprivation, sedating medications, alcohol consumption the previous night, and the chronic loud snoring. Now we move on. For the next slide, we look at the conclusion of that particular study was that there's a strong and direct relationship between drowsiness and traffic accident in commercial drivers. So the primary cause is sleep deprivation, and the authors urge this information to be used by public authorities to develop effective policies aimed at reducing drowsiness-related accidents. Now, for the next slide, now this one. This is a research by Professor Dr. Kanvi Kanitpong and team on the effect of sleep apnea on driving safety. They did the stop-bang questionnaire for screening obstructive sleep apnea in public transportation and truck drivers, and this involved 237 of such drivers. And the stop-bang questionnaire is a quick and reliable screening tool for OSA, the obstructive sleep apnea. And also some of these volunteers underwent the polysomnography or sleep study as well. Now, the study sample included 40 participants, 20 high risk and 20 low risk, based on the stop-bang scores that I mentioned. And the result was that 27 participants, this is 67.5%, had severe sleep apnea. 17.5% moderate sleep apnea, and 15% had mild or no sleep apnea. Now, they also underwent the driving simulation test as well. This evaluated these drivers' performance in a simulated environment under the realistic conditions, and they found that there were unstable driving, difficulty in maintaining a consistent lateral or lane position, and you have the cumulative fatigue effects as well, resulted in the increased lane instability, worsening of the sleep apnea severity, have the high frequency of apnea events, and the lower blood oxygen saturation. For the conclusion, sleep apnea significantly impaired lane stability, leading to unstable driving, which is a key contributor to road accidents. Preventive measures, routine screening, treatment for sleep apnea among public transport and truck drivers are essential. So implementing these strategies could substantially reduce the number of drowsiness-related traffic accidents. A Thai study by Natchira Dachon Ponchai and colleagues addressed limitations in the traditional binary drowsiness classification by introducing 3 levels of drowsiness: alertness, moderately drowsy, and extremely drowsy. And they involved the 10 volunteers participated in the 1-hour simulated driving sessions, and they record their EEG and EKG. Also at the same time, they do the video recording for the observer rating of drowsiness every minute. Now, using assessment from 2 independent observers as ground truth. And the finding was that the system that they use achieve high accuracy in drowsiness detection using minimal electrodes and a simple architecture. So the approach here that they use conducted in Thailand is feasible for real-time monitoring and early warning system with strong potential for improving road safety. So further research is encouraged in this respect. Now, to combat the drowsy driving, what can we do? This is a study by Mitsuo Hayashi and colleagues to see if combining short nap with caffeine, bright light, or face washing can help fight mid-afternoon sleepiness. And they involved the 10 healthy young adults participated in 5 conditions, choosing to take nap only, or caffeine plus nap, or nap plus bright light, or nap plus face washing, or no nap at all. Naps meaning a period of 20 minutes at about 12:40 p.m. The result is that caffeine plus nap more effective for reducing subjective sleepiness and improving performance, with the effects lasting for an hour. And for the nap plus bright light, have got a similar result to caffeine plus nap, but less impact on the performance. Nap plus face washing has mild and temporary effects, but did not reduce sleepiness right after the nap. So in conclusion, combining a short nap with caffeine or bright light or face washing can enhance its effectiveness against mid-afternoon sleepiness. The next one is looking at the effectiveness of additional countermeasures that can be used during a break to help reduce driver sleepiness. They examine whether a short nap, less than 50 minutes, or 150 milligrams of caffeine in coffee, or a coffee placebo impacts the reduction of sleepiness and improves driving performance. And these involve 10 sleepy subjects participated. And all intervention occurred during a 30-minute rest period between 2 1-hour monotonous early afternoon drives in the car simulator. Conclusion is that both caffeine and short naps are effective countermeasures for reducing sleepiness and improving driving ability for drowsy drivers. Conversely, simply taking a break without these additional measures is insufficient. Now, this next one is very interesting. This is the, according to traffic accident statistic from the Royal Thai Police, between the year 2008 and 2018, the number of accidents caused by drowsy driving has steadily increased each year. So in 2019, focusing on the primary highway network managed by the Ministry of Transport, they looked at the road accidents then, and there were over 20,000 reports. 7.02% were attributed to driver drowsiness, making it the third leading cause of accidents behind speeding and abrupt lane changes. And what they did in response was that the Department of Highways implemented several key initiatives. Okay. Now, these include the public awareness campaigns promoting rest before travel and the real-time drowsiness alert system for drivers. And these measures have helped, as you can see in the graph, the reduction in the accident rates due to drowsy driving beginning in the year 2020 and 2021. The first place which considered as the most effective drowsiness countermeasures is the mandatory warning sign plus question and answer signs plus transverse rumble strips. Now, I just give you example. You can see on the right lower corner of your screen. One of them said anti-drowsy zone. Is a dolphin a fish? Another sign will say, are whale sharks whales or sharks? The answer is whale sharks are not whales. They are the largest species of sharks. So these signs grab drivers' attention and mentally re-engage them with short thought and provoking questions and so on. So we're coming to the end here. Warning signs for microsleep. That will include many things, but let me tell you that sudden head nods or body jerks, excessive yawning, frequent blinking, feeling like you just snap awake, those are the warning signs. At the speed of 90 kilometers per hour or 60 miles per hour, just 3 seconds of microsleep could cause your vehicle to veer off the course by nearly 90 meters. So the tip for safe long distance driving is you have to plan ahead, get adequate rest 2 to 3 days before the trip with at least 8 hours of sleep per night. Avoid caffeine late in the day before your trip because it may disturb your sleep. Avoid driving during peak drowsiness periods, which are between 1 and 3 p.m. and 2 and 4 a.m., especially if you are sleep deprived. Share driving duties with a capable passenger, your wife for instance, and power naps. 15 to 20 minutes can be very effective. You have to set the alarm to avoid oversleeping, and you drink a cup of black coffee right before your nap. The caffeine will kick in as you wake up, boosting the alertness. So those are the messages from me. Key point is never drive while feeling drowsy, and as it poses significant dangers not only to yourself, but also to your passenger and also your family. Finally, just to publicize that our association is organizing an international event coming up on the 17th to the 19th of October in Bangkok at the Avani Rashada Bangkok Hotel. and be attended by a number of Thai and international speakers. For those who are interested, you can look up the event details on the website of our association, tlwa.or.th. Thank you very much. Now, we have some questions for our speakers. Let me just pose some of these questions to you. Starting, hang on a second. Okay. Dennis, please. I have a question from the audience for you. What components are included in the comprehensive assessment during the initial visit for the sleep problem? How would you evaluate the patients?
Yeah, so actually, we're using a comprehensive assessment tool called My Positive Health. It's by a working or study group from the Netherlands, and you can look it up by My Positive Health if you just type it in Google. And we have 1 hour with the patient, and we go through several aspects with them. So one aspect is the physical well-being of the patients, and then we also have the mental well-being of the patient. So for each of these aspects, we have a certain of questions or statements, and the patients, they rate themselves from 0 to 10. So we get a really good overview over about their several aspects of health. So another aspect would be social well-being and everyday life as well. Then perceived living quality. And another one is feeling sense of meaningfulness in your life. So these are the 6 aspects we go with the patients through, and we have perceived it as a really good tool to get a good comprehensive assessment. Again, that's My Positive Health.
Thank you very much, Dennis. I have a question for Dr. Narisha, please. A question was that as young businessman who works or travels often, is it safe to rely on melatonin every night? Any concern on it for long-term use?
Okay. Well, thank you for the question. So basically, melatonin can be used particularly for the jet lag disorder. So yes, during travel, you can actually time melatonin. Usually, if you go to the destination, and you can try taking 3 or up to 5 milligrams about half an hour prior to sleeping time at the destination time. The recommended dose should not exceed 5 milligrams. Yes, it can be used. It's relatively safe if you use it at the optimal dose. However, you can sleep by yourself, changing your sleep hygiene and things like that is probably the best without anything.
Okay, thank you very much. Next one for Dr. Wolster, please. What are your recommendations for sleep health in shift workers, for example, policemen, military personnel, and the healthcare workers? Is Dr. Wolster here? Dr. Wolster, are you here? I can see Professor Rush. Can you give a response to this question, please?
Yes, so I think in general, shift work is necessary in our society. So thanks to all the people that are actually doing it. From a sleep perspective, this is of course hard for the body, especially when you get older. So I think it's hard to say, but at some point when it's really taking too much of your energy, I think it's also maybe a hard decision to say, I want not to do shift work anymore, but of course, of private reasons, sometimes that's not necessary, not possible. And as I say, it's necessary that some people are doing these jobs, like policemen and others. So then, of course, all the other topics we heard about are important. So try to do a regular sleep schedule when you're not on shift work. Try to follow sleep hygiene rules or tips that we heard. Try to do longer shifts so that you don't change so many times. So maybe be on a shift for several days and then have a good recovery period. I think generally these recovery periods are very, very important. So really take the signals of your body seriously. Also accept that shift work is hard. I think that is that it will affect your body and your sleep. I think it's something to be concerned about, but not also to worry too much about. In general, yes, take your signals of your body seriously. Especially as I said, if you get older, it can be that it's harder to cope with, and then maybe do less shift work.
Thank you very much. There's a question about for Dr. Thanita, please, about breathing cycles. The person who asked the question said that the breathing cycle have increased over the last decades, roughly double from 8 to 12 per minute to 12 to 20. Now, how important is the normalization of breathing via mindfulness practices?
This is very interesting question, and thank you for the question. So actually, mindfulness is like being aware of anything at all. So it means there's no need to control your breath at all. So you don't need to change anything. Either you are breathing fast or slow, that doesn't matter. So mindfulness is to bringing the attention or awareness to your breath. If you want to focus on your breath, that's how you bringing attention on your breath. And the new breath is the new beginning. So you just bring curiosity to your breath. But when you talk about the breathing practice, so we can see it as the stress management. And there's a lot of research around that. So when we talk about breathing for stress management, so normally people are going to say doing the abdominal breathing, which is it mean having very full breath and then maybe breathe out through your mouth like that. That also help with your stress level. Or people, there's also the research about long exhale. Like for example, you inhale 4 breaths and then exhale 8 breaths, something like that. That can also reduce the stress. But the latest meta-analysis kind of show that if you really want to focus on using the breath as reducing stress, you can just breathe slow, and the ratio doesn't matter. You don't need to count your breath, whether it's going to be 5, 4, 8, not anything at all. Just keep your breath slow, which means less than 10 or 6 per minute. I mean, 10 or 6 rounds per minute. That's gonna help with the stress relaxation.
Okay, thank you very much, Dr. Thanita. A question again from Professor Rush, please. There's a question about most corporate teams struggling with burnout and decision fatigue. What are the simple sleep practices or mindfulness practices that really help boost clarity to improve the work-life flow? Would you your suggestion on this?
Yeah, that's of course also a very complex question. I think sleep is probably one of the very sensitive indicators of upcoming burnout. So I think its first tip would be to take sleep problems seriously. So because this will be an early indicator of maybe having too much expectations and overload in various areas of your life. And I think in general, there's also studies showing that sleep disturbances can predict burnout development 2 years later. So I think it's really should also be taken seriously by companies or maybe they should even regularly assess sleep health in their employees. I think in general, burnout is of course has a lot to do with how much do you expect of yourself, how much do you take on you, and of course these people are also want maybe also to perform well on sleep, which is of course then counterproductive as we heard. So if you really expect that you sleep very well all the nights, then you might even run into this worrying problem. So I think in general, sleep and burnout are highly interrelated, and a good sleep hygiene, a good sleep health, and all the tips that we heard today, sleep regular, sleep efficiency, and all these things are very important for in the work context. But we should not forget that burnout is not only related to the work context, but can occur also in private life. So I think it concerns everybody who is really just overloaded by a lot of tasks in their life.
Okay, thank you very much. Dr. Narisha, there's a question for you further on, following the answer about melatonin and melatonin use in relation to cancer problems. Is it okay to use melatonin during treatment for cancer, for instance?
Yes, I have to say that, melatonin is a natural hormone, so it's relatively safe to use in the general population or even in cancer patients. Again, you can try, it doesn't work all the time, but if it works, then, I think it's very safe. Of course, modulating sleep hygiene is also very important. And with cancer patients, they might be on other medication. Make sure to look for the side effects that may cause insomnia on some of the drugs they were using.
Thank you very much. Dennis, I think we should wrap up now because we have gone beyond the arranged time. Do you have any final words from our symposium today, please?
I'm grateful to all of the speakers that showed up today and showed their expertise. I think that's a wonderful example of international cooperation. I'm also very grateful to you, Jung-Yu, that you made this possible.
Oh, thank you.
And I hope there's many more events like this in the future to come. So thank you very much. And thank you for everyone that were listening today. I hope you got some valuable insights for your sleep and sleep quality.
Thank you very much, Dennis. And thank you very much all the audience who've been following our program since 8 p.m. Thai time. We run to almost 10 p.m. time or beyond 10 p.m. Thai time. For our future collaboration symposium, the next one, we hope to hear feedback from you and what topics would be appropriate for both Thailand and Switzerland. And so we hope for this to continue and hope that we can share our experiences together. There are many issues that I think we can follow on, particularly the differences of sleep problems in Thailand. I think it probably exists just like in Switzerland too. So from Bangkok, Thailand, have a very good night, good evening for you and good night for Thailand, and see you again soon. Swadee krap. Goodbye. Thank you.